This year's award goes to Professor Mohammed Shamim Khan from Guy's and St Thomas Hospital. Just a brief minute, because we have a very nice tribute video from one of his previous trainees who's present in Australia that I'd like to play for you. But Mr. Khan really, I think everyone around here can appreciate or know that he is probably one of the best trainers. I haven't worked for him, but I've met him at various educational events, and he's always left an impression on me. So without further ado, I'd ask Brad if you could play the tribute video to Professor Khan. Thank you.
Ladies and gentlemen, Chairperson of SURG, thank you so much for inviting me to present a tribute to Professor Khan. Professor Khan has been awarded the SURG and Carl Storz Silver Cystoscope Award for the most influential trainer of the year. There are very few clinical trainers who've had such a lasting influence on a generation of urologists, not just in the South Thames, but across the UK. And Professor Khan is an example of one of these clinical tutors who's not just a teacher, but a role model for all. He's an incredibly kind, compassionate, knowledgeable, and incredibly skillful surgeon. And he's demonstrated a great degree of enthusiasm and dedication to all urologists who've had the pleasure of training with him. He has deserved all the prestige and respect that he's and is very worthy of this award. Mr. Khan's contributed to the training and education of urologists and the development of the training curriculum in urology in the UK through his role as the BAUS Director of Education. He's enhanced the quality of the FRCS revision course and has established a whole bank of questions which we all go through when we do undergo the course. He's recruited a number of subspecialty experts to help vie the students and has delivered mock examinations and lectures on a routine basis through this course. He's also developed the Introduction to Urology course for recruitment into national selection, and aspiring urologists have all commented on how high the quality this particular course is. I have my laptop here to remind me of all the accolades that Professor Khan has achieved. He's incredibly engaged with training at a national level. He's a member of the Specialty Advisory Committee and a member of the National Panels of Selectors for Urology Training in the UK and Ireland. He's instrumental in setting up a simulation course at Guy's Hospital, and he currently supervises a number of PhD students and research fellows in simulation. He's developed the first simulation training program for Southeast specialist urology trainees, and Mr. Khan remains a national co-lead for simulation in urology. The simulation curriculum has recently achieved GMC approval and has been incorporated into the specialty urology curriculum. Mr. Khan is instrumental in training at a regional level. His firm is coveted and respected, and is very popular amongst many trainees. He's gone on and developed a Royal College of Surgeons of England approved fellowship program in bladder cancer at Guy's Hospital. He's trained over 30 urologists in general urology, reconstructive urology, and robotic surgery. Of these, many have gone on to undertake consultant posts in academic and district general hospitals, as well as becoming professors throughout the country. Perhaps one of the most lasting images of Mr. Khan, which will remain with me forever, is the fact that late at night, when I got called in during my tenure at Guy's Hospital, there he is vivaing the next batch of FRCS students. And this is about 11 o'clock at night, and these sessions will often go on till midnight. This is all done in his own time, and he's really keen on supporting all students throughout the region in passing their exam. He's particularly keen on supporting trainees in difficulty and pays them particular attention. He encourages them, invites them to further tuition and practice. Mr. Khan is an exceptionally talented individual. He is a remarkable human being, and if I could be half the human being that he is, yet alone half the surgeon he is, then I'll be doing well. I'm incredibly proud of you, Mr. Khan, and I'm incredibly proud of having trained under you, and I think you are thoroughly deserving of this award.
I'd like to invite Mr. Khan to come up.
So we'd like to award this year's Silver Cystoscope Award to Professor Khan. So if we could get Professor Khan's slides up, please.
So, good evening, ladies and gentlemen. I'm very humbled on being awarded the Silver Cystoscope. Firstly, I must thank STORS for giving away golden and silver cystoscopes for many years for different achievements. And obviously, I am very grateful to SURG and its members for voting for me to be awarded this cystoscope, the people who nominated me and wrote the citation, and which led to this award. I have a confession to make. Personally, I feel that I am nothing because I can't achieve all this on my own. There are hundreds of people who have worked toward this day. And amongst these are my esteemed and fantastic colleagues from Guy's Hospital. They have been extremely supportive throughout my career at Guy's. There were hundreds of people from the country, up and down the country, who devoted their time and energy to run the courses in different parts of the country. And I can't thank them enough for doing this. There are a few of my colleagues and friends from this country and abroad who worked and helped me with international work. And last but not the least, my family. Without the support of family, you can't achieve these things. And I'm grateful to my wife and my children. When we talk about the training, I just chose a topic, the training in urology at Crossroads in UK, that we must be looking at 5 to 10 years ahead. Now, what are the challenges we are going to face in urological training? And in my opinion, there are about 8 things. And these challenges include the technological advances, rising healthcare costs, concerns about patient safety, higher expectation of patients, aftermath of EWTD, explosion of knowledge, reversing gender disparity, and increasing life expectancy. I think a lot of these things were covered in Kieran O'Flynn's address, but I just want to touch base with one of these things. The surgical training has been modeled on the Halstead's principles of see one, do one, and teach one. But this was about 100 years ago, when he only had very limited number of instruments, and what he could do was essentially open operations. But we realized over the years that open operations are associated with bleeding, infection, and pain. What happened in 1991, Ralph Clayman published his first paper in New England Journal of Medicine as the first laparoscopic nephrectomy. And this was the dawn of minimally invasive laparoscopic surgery in urology. It was only 80 years later, robotics came into urology, and there are 4 generations of Da Vinci robots. Robotic revolution has taken the whole world by surprise. I know that there was a lot of resistance in UK about robotics, but today, if you see, it's only upward trend. So I feel that for the surgeons of 21st century, the Da Vinci robot is the scalpel. But there are others in the pipeline because there will be more companies coming into the market. What these technological advances have achieved: reduction in bleeding, pain, and infections. Better cosmesis, but it has come at a price. And what price is those? Increasing healthcare costs. UK's 150.6 billion in 2013. Increasing and longer learning curve. And there is increasing distance between the patients and the surgeons in the operating rooms. So as a consequence of these innovations, we are increasingly dependent on others to perform the surgical procedures. We were talking outside with Toby that we have physician assistants, surgical assistants. We are increasingly dependent on others, and therefore teamwork and communication have become very vital in our day-to-day practice. And with these technological advances, the instruments have become much more sophisticated and complicated. The Da Vinci robot, which we use today and pay about $2 million to buy it, it has been associated with many deaths and many injuries in United States. Because it does not have its own brain, you have to drive it. And if you don't know how to use it, it will cause harm to the patients. There have been several landmark reports within UK, Bristol Inquiry, Harold Shipman, and Francis Report. What all these reports demonstrated that about 3/4 of the problems in healthcare occur as a result of human factors. 3/4 due to poor leadership, and about 60% due to communication breakdown, which I personally think is so important in our day-to-day practice. So if you want to become a good urologist today, you not only have to have technical but non-technical skills. There was a session on non-technical skills at BAUS this afternoon. What the patients expect in 21st century? They want instant attention. They want infinite time when they come to your consulting room, quick diagnosis, immediate treatment. And they want to have surgery which is completely painless and curable. European Working Time Directive. I think in the recent times, this factor has influenced our training in a very big way. It has not only impacted on our current training, but also influences our attitudes towards the working time in our daily lives. That is why we brought the simulation into our surgical practice. We thought that this might help you in shortening your learning curve. But it was criticized because there was no evidence base, and hence we embarked on a randomized trial to gather some evidence whether it makes any difference in real life or not. So we embarked on the Simulate trial, which was actually started in UK, and many of you might have been approached to take part in this randomized trial. What has happened so far, although we started this in UK, but we didn't succeed in recruiting enough trainees into this trial, and hence we have to approach other urology departments and the friends, other countries, Japan, China, Turkey, and even as far as Canada. There are 6 trainees who are traveling from Canada to come to GAIS to have initial simulation training. what I request those who were kind enough to participate or volunteer to take part in the trial, that we need data from you. This is a British trial, and it would be a shame if we do not have enough data from UK and we report this trial based on the data from the other countries. So may I request you, please help us and send us the data. There is explosion of knowledge. It is frightening because knowledge is expanding, journal knowledge in journal about every 12 months, but soon to be every 12 hours. What about the medical knowledge? The medical knowledge is going to double every 73 days. As a result of all these developments, expansion of knowledge, the urology as a specialty, when I started my training, it was being practiced by the general surgeons. Then had a species of general surgeons with special interest in urology. Then came the urologists, then urologists with special interests, and now the super specialists. That is how the things have moved on. There are at least 8 subspecialties of urology today. And I assure you, in 5 years' time, the number will be double. So currently what we are doing, we are trying to learn something about everything and everything about something. But in few years' time, it will not be possible to learn everything about something. Lot of females in urology. We welcome you all, but you have different social responsibilities, and therefore we must be conscious of that your working patterns may be different from men, and there is no question that the future will be females. And last but not the least is the demographic time bomb. Increasing life expectancy, a female child today, born, expected to live about 93 years, and male about 91 years. So what the aging brings: incontinence, immobility, instability, insanity, and iatrogenesis. And therefore, we have multiple pathologies in this elderly population, and hence we need to learn how to work with other disciplines in our daily practice. There's no doubt that the aging population is putting all doctors in the front line of geriatric medicine. The Department of Health had a concern that we are increasingly subspecializing and producing doctors who are unable to deal with the complexity of multiple pathologies found in most older people. And therefore, they gave the task of coming up with some solution to Professor David Greenway, who is actually a professor of economics. He was a vice chancellor of Nottingham University. And what are his special interests? Export and productivity, international trade, and economic development. So he came up with 5 major recommendations. What are those? Full GMC registration when you qualify, CST rather than CCT. CST is Certificate in Specialist Training, because he believes that you never complete the training. So you shouldn't be CCT, it should be CST. Rounded specialist. That means you are specialist but also a journalist. The journal care should be provided within specialist areas, and you should spend a year, for example, in elderly care medicine, so that you become conversant how to manage the elderly care people in your practice. I personally think they are based on common sense, but not practical. At Guy's Hospital, we have realized that increasingly we are dealing with the elderly care population, and therefore we have joint ward rounds with elderly care physicians. They assess our patients preoperatively, and in day-to-day practice also we do joint ward rounds, discuss each patient with their social and medical problems. So this recommendation of going toward more super specialization back to journalism, personally, I don't think it is very sensible and pragmatic, because the people who have got vision for the future, what do they think? They think that since we live in an age of innovation, practical education must prepare a man for work that does not yet exist and cannot yet be clearly defined. I think that would be much more pragmatic approach towards future generation of our trainees and urologists. So you as trainees, your dilemma is aspirations, you might like to specialize in certain things versus needs of the society. So one pushing you forward and other backwards. You have to be flexible, but be mindful that we are part of the international community. We have to keep pace with the progress in the rest of the world. We can't isolate ourselves from the rest of the world. What the future? Future is something we do not just simply enter, it is something which we create. So whatever type of future you create for yourself and your other followers, but remember few basic principles of being a good doctor, and that is actively listening to the patient, effectively communicating with your patients, thinking logically and rationally, doing things safely. If you can't do it yourself, ask somebody for help, and the most importantly, with utmost empathy, treat every patient as if he was your family member. I thank you sincerely for listening to me and for the award, and wish you all a very happy career in urology. Thank you very much.
Thank you, Professor Khan, for your take on the future of urological training. We have 3 talks today about urological training, so we'd like to take questions at the end of all 3 talks, and we'll invite the panelists back up at the end. I'll hand over to Jonathan to introduce the next speaker.
So the next speaker is Mr. Toby Page from Newcastle. Mr. Toby Page is a consultant urological surgeon who specializes in minimally invasive techniques in kidney surgery. He's also the BAUS education lead for medical students, and I think in a time where the medical students and core trainees and foundation doctors' interests may be possibly falling, I think it's important that we shed some light on how we as registrars can get them back into urology. Mr. Page.
Well, thank you. I'm really, really excited to be here, actually, because I think you people here, the younger ones, not the older ones, are really important to actually keeping urology alive, keeping it as a speciality going, because exactly as Jonathan says, we are at a little bit of a problem with medical students particularly, and I'll talk a bit about that. So what is interest? You know, interest is, we heard Professor Khan talking about interest, quite an interesting idea, but it's all about enjoyment and excitement. That's what interest's about, and it comes in 2 stages. The first one, we've got a typical medical student here in 1990-something. First one comes, you've got to have something that really grips you, and it's a psychological state of excitement and arousal, and that's called situational interest, and that's where I think we all have a real role. When we meet medical students, foundation doctors, core doctors, you've got to find something that's really going to attract them, and it could be something novel, and we'll talk a little bit about that. We've heard a lot about robots. I've been using that as a novel key to get medical students involved with urology. And once you've done that, you've got to get them to re-engage. And you have situational interest, and it's got to be something that actually gives immediate reward. I'm afraid people are busy, particularly medical students have a lot of demands. They've got sport, they've got learning, they've got social life. They need something instantly tangible that gives them some benefit, that makes them think, surgery, urology, I'm interested in this. Once you've done that, you've actually got to make it stimulating. If you just give them money, they're not going to be very excited about that. It's not stimulating. It's got to have a cognitive or thinking element to it that makes them think, actually, there's something more to this. So they develop an interest that they can then continue with. Some of that has to be self-regulated. We cannot lead people down a path the whole way of their career. It will not be interesting for them. They will lose interest, and really they have to develop their own self-regulation. They have to persevere with it, and this is the big problem for all of us. When we meet doctors, you'll meet them briefly for a few weeks, medical students, you think, this guy's brilliant, he's great, and you'll give him something to do, and you'll think, fantastic, I've really helped someone, and then he disappears. And we've got to think about how we keep that persistence of that link going, really important. And once they've developed that personal interest, it's really helping nurture it. So we've got to think about tasks that are meaningful and involving for them, and once they develop, keep going. And I think that's where particularly registrars, senior core trainees, you've really got a much more active role. You're much more accessible than consultants, trainers. You're there, you're on the floor, you're with these people day in, day out. You know, get to know them, give them your Twitter, give them your email, give them your phone number. Try and interact with them as much as you can. The place, and Jonathan hinted at this, where we're working at the moment could not have been more hostile to actually developing lasting interest. Everything is against us. Medical school is against us. Foundation year is against us. These people are moving around, they're busy. Then some of them, and I'll show you a slide in a minute, aren't even with us anymore. They're disappearing. We don't know where they're going. So we've really got a very difficult landscape to work against. The voting slide isn't working, so you just have to have a little show of hands. This is me as a house officer in Plymouth in about late 1990s. That's when I first had situational interest in urology. But who here, if you think back, who was interested in urology as a career, as a medical student? Anyone? Oh, quite a few, 3 or 4 people. What about as foundation doctors or house officers? Wow, that's really surprising. So that's very interesting. I'll show you a slide in a minute why that's surprising. And what about in core surgical training? So yeah, the majority by that was sort of what we'd expect. So once you think about the problem of trying to bring people into urology, you can think about where you go, and you can look at places called context personalization. That is where you already have a group of interested people. And that's quite a good place. We can look at core surgical trainees. The majority of you there say that's where your urology interest developed. And that's obviously important. But it probably won't expand the pool of possible urologists in the future, because most of those people will become some form of surgeon and probably a urologist. And perhaps what interests me more is trying to get people who'd never thought about urology, never thought about surgery as a career. Because actually, once you're in core surgical training, the majority of you are going to become a surgeon, and most of you that have contact with urology will hopefully find it interesting. If we think about the things that we can offer as trainers, as mentors, as guides to medical students and junior doctors, we've got to think about things that they're not expecting to be involved in. So one of the things I've been doing up in Newcastle is getting the medical students in and getting them on the robot. I fully accept it has no practical learning point for them. It's novel, it surprises them. I'm allowed to touch something that costs, millions of pounds. Yeah, of course you are, get on it. It's a complete novelty, but it immediately allows them to engage with surgery. I never knew about that. Actually, we can talk to these surgeons. They're approachable people. They're not in a funny uniform, in a funny place where we can't go, we can't touch anything, we're told to be quiet if we talk. So it's just breaking down those barriers, and it surprises them, and then their interest is developing. If you think about yourselves here, what was the individual trigger that made you interested, perhaps in core surgical training, on urology as your thing? Have a think about who was it who met an individual who made you think, actually, I like that person. I could see myself being like them or working with them or perhaps developing into them. Who has that as a role model, as a reason for becoming a urologist? That's interesting, yeah. So maybe perhaps about a third of you. What about when you worked as a urology trainee, perhaps as a foundation F1 in busy urology? Did that make you think urology was a great career? Anyone? Oh, wow, that's really surprising. I was very surprised. And what about things in the media? You heard about robots, you heard about reconstruction, or all new technology. Did that make you think urology is a good place to be? No one. Wow, wasn't expecting that. I thought technology would be a big thing. And what about the breadth as a speciality? Did that attract anyone? I think there's so much that you can do. Yeah, a few. Interesting. Good. So I set up some focus groups in Newcastle, and I sat down with 100 medical students in 4 groups of 25. It wasn't voluntary. They had to come and talk to me. They were there for something else. I cornered them. And I asked them about surgery and asked them about urology in a sort of didactic interaction type setting with them. And one of the things I asked them is, what makes you engage with surgeons? What makes you come and think about a urology career? And unanimously, it's about personality and people noticing they're there. If you see a medical student on the ward, you ignore them, they won't engage. If you go up to them, say, how long are you here? What are you doing? What do you know about urology? Come and have a look at this. Instantly, they think this is a better place to be. It's common sense, but you will see it all the time when you see medical students, foundation doctors. I wouldn't say they're being ignored, but they're not being embraced. They're not being welcomed in. And that's the biggest theme from them, is they feel isolated. Some of that's because of their curriculum, which we can talk about, but they have very little surgical and very, very little urological exposure, which is a problem for BAUS to address nationally. The other thing that's very interesting is if you ask them, virtually all of them, a few blokes, but a lot of them believe that they don't have any ability in surgery, which is completely untrue. And it's very interesting. We then took these groups and we did a lot of simulation with them. We put them on Da Vinci, did sim endos, lap mentors, some laparoscopic work, some tissue work. And what was really interesting at the end of that, at the beginning, 10% thought, I might have a career in surgery. At the end, 15% did. And of those 5%, the majority were women. And that's probably because they just thought they had no ability in surgery, didn't interest them. You put them on a simulator of some description. We had prizes every session for the best scores. It was a girl every time. And it was real eye-opener. And you'd say to them after, have you thought about career in surgery? You've really got something there. And they said, no, I never thought about it. I didn't know I had any ability. And it's just interacting, telling people, helping them to get there. What about foundation years? I mean, this is a real problem for me because I work in a big, busy unit. Some of you here have probably worked with me, and it's a very difficult time to promote urology. If you're an FY1 or 2 and you're running around, you're clerking, you're prescribing, you're sorting out x-rays, it's a hard time. And I think that's where urology actually can be a very difficult speciality to promote, because we are a high turnover, busy speciality. You've got lots of demands, you've got mandatory training, you've got shifts, you don't work in a firm anymore. All of the things that really promote a feeling of bonding and being in a team have been broken down. So very hard to keep people's interest in foundation year. This slide probably doesn't project very well, but the blue are F2 doctors who went on to some form of recognised training. This is just the northern data. I haven't got health education England for the whole of the UK, so it's just northern foundation school data. 36% of F2s went into a recognised training post. I mean, that's a staggeringly low number. The little red area, 14% who went into non-recognised training, so that's neatly 50% carried on with some training. The other 50% of northern F2s went off somewhere. We don't know how many are going to come back. We don't know what they're going to come back to. I mean, that's an enormous attrition rate that we need to really think about. How do we stop that attrition? How do we keep people's interest to keep going? And there are lots of reasons why people are leaving. One of the things I really wanted to look at was FY exposure. And right at the bottom of this slide, it says that in FY1, it actually has quite a lot of exposure. So 8.3% of FY1s will have some urology exposure. What about the other 90%? They're not getting any exposure to what is the third biggest speciality, surgical speciality. After T&O and general surgery, we're right up there. And yet only 8% are getting exposed to urology. At medical school, the actual exposure is even less. And yet we're number 3 in the table with a big, busy speciality, and that message isn't getting through. What about what happens afterwards? And there was an interesting comment from Kieran O'Flynn's talk about run-through training. And here, the blue shows trainees at the end of FY2 who stayed in region. And all the other colours are all the other regions. And what it shows is that people actually want to stay put. And I think one of the problems with traditional surgical training is that you had to move a lot. And that's disruptive for training, it's disruptive for your life, disruptive for your friends, it costs money, and there are a lot of downsides. And actually, although people are perhaps not keen on run-through training, I think there are a lot of advantages in keeping up interest, keeping up contact. And this slide really shows people do want to stay put. And I think if we can facilitate that in urology, and do have some run-through training and help people have the balance that they want, they'll keep interest in the speciality. So what can we do? I think it really comes down to every individual to take some responsibility. When you see someone who's looking a little bit lost, particularly medical students, particularly in theatre or an environment, you're doing some form of intervention, involve them. They want to be involved. They want to learn. They're like all of us. They're bright people. They just need that little push to get involved. And if we all do that, they'll come back. It's what happened to me. It's what happened. I saw Prokar putting his hand out. What happened to him? You meet someone, they embrace you, they get that interest going, and then once you've got that link, somehow try and keep it going any way you can. We had a little talk in the core surgical training thing, and actually Ben Chalakan was saying, get involved with audit. I think this is really difficult. We all have to do audits, but I think try and avoid mundane tasks. Please involve them, but don't say to that medical student, FY1, I've got this great audit, there's 100 notes. It's going to be brilliant. Sit there in a room going through it. Get them involved with papers, but don't give them long, mundane tasks to do because it'll just turn them off. It won't be good. One of the things for me in BAUS to do is we are going to work with medical schools to try and increase the amount of exposure on the curriculum at the medical schools, but it's so hard because now they're competing at all primary care, all these other subjects that weren't really included that they have to fit in. But it's a message for BAUS to go out there and say urology really is a big surgical speciality. We're grossly underrepresented in the medical school curriculum. Thank you. My final plug, it's gone off your deleted, the BJUI knowledge base is fantastic. We have agreed that any trainee can have free access as long as they register by the end of July. There it is. So if anyone's not using BJUI knowledge, you should be. It's absolutely peer-reviewed. It's a fantastic knowledge base. If you're a member of BAUS, you get free registration. If you're not a member of BAUS, you can register as long as you register before July. Go on the website. It's brilliant. I'm one of the sub-editors. It's a fantastic resource. I wish I had it. And please use it because it's there for all of you to use. Thank you.
Thank you, Mr. Page. So for everyone in the audience, you can actually ask a question on the app. So particularly for our next talk, there may be some issues which you have that you don't want to voice out loud. You can do it on the app if you go to ask a question and enter the session number. So without further ado, I'd like to introduce our next speaker, Mr. Roland Morley. He's a consultant neurological surgeon at Imperial College Healthcare NHS Trust and is currently chair of the SAC for Urology.
Right, welcome and thanks for asking me to talk. We're actually not going to talk about Brexit. I know it was in the original title, but actually we don't know what's going to happen with Brexit and doctors in the UK or Europe for that matter. So I think that will have to go over to next year until we know where we are. Now, I know one of the salient topics, and you're voting for later on, is on the Improving Surgical Training project. And I did briefly introduce this last year. It's been a big topic of discussion nationally. It's been a big discussion at the SAC. And certainly in the background, a number of trainees have been talking about it. Now, where we are with training at the moment is we've got, as Toby Page has already said, we've got the undergraduate training. We're doing 5 to 6 years. We then do foundation, we do core, we do speciality training, and then we do specialist training. And if you look very carefully with the specialist training, we have what I would say is 1 to 3 years of specialist training towards the end, just before CCT and thereafter, which is unregulated. It's generally subspecialist practice. There's no formal assessment. It can occur in any of a number of hospitals. But the important thing to realize with that training, which you've all been asking for, is that it's been relatively unregulated, whereas the speciality training, as it stands at the moment, is regulated. But there's a big problem out there, and Toby Page has already alluded to it, and that is the problem with the number of trainees who are coming through medical school and into foundation who give up. And in fact, only 40% are actually going on. And what was quite interesting was the showing of hands that you gave out there about the number of you that are actually in urology, having expressed an interest in urology early on. And it was approximately 50% of you. Now, where we are with the core surgical training is that a significant minority are unhappy with the core surgical training that they're getting. And because the core surgical training is being a bit of a problem, the report that Toby Page referred to and subsequently has been acted on as far as surgery is concerned was the Improving Surgical Training, which was a report commissioned by HEE to look at how we could improve surgical training. And the remit of the report was as follows. I won't go through that list there, but the context was that from the Greenway and from Sir Simon Wesley's subsequent report, there was a loss of autonomy within surgical training. There was a loss of support structures and loss of the relationship within surgical training that existed. And one of the things that's sitting behind there, regarding that dissatisfaction, particularly with core surgical trainees, is this was work that was done by Ian Eardley in his role as lead nationally and SAC chair previously, was that particularly in the smaller hospitals, if you look at the top, particularly related to the green, that quite a lot of trainees doing core surgical training were actually just delivering on service and delivery of service for very little daytime allocation to surgical training. And if you look at it in a bit more detail, what you actually find, particularly here, is that a lot of that work was taken up in the daytime between undertaking ward rounds, discharge paperwork, other admin tasks, and clerking new patients. Now, clerking you would see as a bit of surgical training, but there was a lot there that not specifically surgical training. So foundation doctors and core trainees not doing a lot of surgical training. And when you actually look at the logbook experience related to surgical trainees with appendicectomies, okay, you've got a great big maximum there, but the mean number of appendicectomies done in your core surgical training was 6 over a 2-year period. So surgical experience in terms of training at core level is not very good. And so as part of that, one of the things that Ian Eardley started looking at in terms of improving surgical training in general for all the surgical specialities, but us also looking at urology, was to see how we could actually improve that. And the theory behind improving surgical training is that foundation will be largely unchanged. But then the question is, as Toby has already put to you, is how do we get the trainees interested in foundation? And that's the role specifically that BAUS and Beck will be addressing. But once you're into surgical training, then, as has already been mentioned, the need to have more of a generalist, but be very emergency capable. And within surgical training in urology at the moment, we're not all emergency surgically capable, but to have a competency-based system. And for those of you who don't realize, you're actually in a competency-based system already. It's just that it does have a time allocated to it. But within the improving surgical training, no reduction in surgical time training, but having a competency-based system. And for those that are able to demonstrate expertise and competency is within this centrally funded, quality-assured end of training, approximately 25% of trainees would be able to apply nationally for a competitive interview for subspecialist training. So that's what's sitting behind it. Now, HEE are actually very keen on making sure that it's cost neutral. So what we won't be able to do is put extra money into those centrally funded, quality-assured fellowships. Now, what is sitting there behind the selection for IST? Now, the premise behind it is that a number of deaneries have been asked to express an interest in the improving surgical training pilot. For those surgical specialities that have expressed an interest, a trainee will have the option as follows. They can go and nominate, I want to be in a run-through pilot from ST1. Or they can say, I want to do the current training that is sitting there at the moment. In other words, you go into core training and then you continue to hire training through national selection at a later date. Or you can say, I'm actually I'm interested in both or neither. So you can just go in a pilot or core, and then they will allocate you to which one you want to go. Now, the reason behind this and the way they're doing it is to avoid selection bias going into improving surgical training pilot project. Now, the reason for that, and Toby Page has already alluded to it and has all been expressed before, is if you are a good surgical trainee and you express an interest in neurology early on, you may well actually say, yes, I want to stay in the same place all the time. And we've already heard that as being geographically in one place is what people want to do, particularly the women amongst us. And to avoid the selection bias, they've given the option there so that we keep the selection bias to as low as possible to keep everything on even keel. Now, one of the things behind the project is you've got to have an extended surgical team to make it work. And with having an extended surgical team to make it work, how are we going to make this work so that we have core trainees doing more core surgical training and neurological training early on? And it means use of all these people here. Now, that is a risk because as far as HEE is concerned, we actually don't know where we are in terms of all these being available for when the project actually starts. And I'll come to that here on this slide because the current status as it exists at the moment is that general surgery have their pilot due to commence in 2018. They will be recruiting into ST1. The SAC has agreed to support run-through with benchmarking at ST3. Where we were a few months back is that general surgery were not happy with run-through trainees not being benchmarked at ST3. What I mean by benchmarking at ST3 is at present the core trainees coming from core to higher have to go through a national selection and have to achieve appointability. For those of you that are not familiar with appointability, but you've been through the national selection, you have to achieve an Angoff score to be in a appointability position, but actually that score is relatively low. And as it stands at the moment, around 80 UK posts are volunteered to be a part of the pilot. Where we are with urology, we've made an application to HE for a decoupled pilot, as the SAC and general surgery had done. General surgery have actually been told they can't have the run-through, but they can have, can't have decoupled, but they can have the run-through with benchmarking. Urology effectively was supporting general surgery because we wanted the benchmarking with the run-through trainees at ST3. HEE have actually come back to me today and have actually said we can't have decoupled pilot, but we can have run through with benchmarking, similar to general surgery. So that addresses the concerns that general surgery and urology have. Vascular surgery have made an application for HEE for run through and have had it accepted, and they're not going to have benchmarking at ST3. And trauma and orthopedic surgery, I have expressed a very strong interest in now going through a run-through pilot and not having benchmarking at ST3. Now, the important thing here is, from a urological point of view, is we need to be thinking about a mixed economy, both in terms of trainees going in at ST3 and also going in ST1. If we only have the present system that we have at the moment, and with 40% of all trainees not going into higher training, i.e. medical or surgical, we will have a situation where the majority of the other specialities are either doing run-through or have a mixed economy. And if you don't have a mixed economy or run-through, you will eventually end up potentially with a lower cohort of trainees coming into urology, and the best trainees, because of geography and the availability of ST1 training, taking it up at an earlier state. And where we are with the pilot sites at the moment is these are the pilot sites that are there. Some, particularly London, are still waiting to confirm but have expressed an interest. All core surgical training posts in Scotland will be entering the pilot. So if you are in Scotland, you will have to be in the pilot going forward. And As part of the IST, the main recommendations are as follows. I don't want to go into those in too much detail, but suffice it to say, with the Improving Surgical Pilots, there will be a rewrite of the curriculum and an enhanced ARCP, and some of the things I'm going to discuss shortly will be in there, but it does have a risk in terms of service, because if you're going to deliver IST, core surgical training will be taking place in larger units. The GMC have just come out in the last few weeks with guidelines for delivering training in the future, and they're talking about entrustable professional activities. Effectively, what that means is providing evidence for core capabilities, and you will have to be assessed and provide evidence on ward rounds, surgery, post-operative management, etc., and the capabilities with that. But it does mean that potentially we will have funded, quality-assured, subspecialist fellowship training that we have been talking about for years but have not been able to have it because of funding. The problem we have at the moment is that we're inflexible within our training. There's inadequate time of training, particularly in the early years, and there's imbalance of service and training, particularly at core, which is potentially what you're going to have to vote on later on. What are the other things that are happening? I've already alluded to the new GMC standards in terms of training. I would just advise you to go to the website and look at the website at the GMC for the new standards if you've got time. It is a long document. It's over 70 pages long, but there is a lot of information there. What are the changes that are happening more locally? I know Professor Khan's talked about where we're going to be in 5 to 10 years' time. There's a well-established boot camp at the moment, and within that boot camp, we're also talking about bringing in the non-technical skills as well. One of the single biggest problems that we have at the moment is the provision of the emergency-capable urological surgeon. Most of you will come through urological training with not being able to have reasonable exposure to emergency urology. However, the expectation when you're a consultant is there is absolutely no doubt you will be exposed to emergency urology and you will have to deal with it, even though you may not have seen it during your surgical training. So we're really talking about an ST5 boot camp. This is being well developed and well advanced in terms of the content as far as BAUS is concerned, and will be available towards the middle or end of next year. For the ST7, we are going to be developing a urology-specific leadership and management course that really makes you capable, rather than the general courses that are available, for urology consultancy. Now, it's very important to realize that we shouldn't be delivering just at ST7, because the non-technical skills have got to go through from ST3 right the way through to ST7. Indicative numbers are going to be reviewed, and as I've already mentioned, the curriculum as far as the project will have to be rewritten to take the new GMC standards. Where you are with your ARCP outcomes at the moment, it's no longer my responsibility to sign you off. It is the responsibility of the TPD and the liaison member from the SAC. It's only when there's a dispute that I now actually get involved. The important thing with this is, from your point of view, is you really need to look at the CCT guidelines 6 months ahead of time to ensure that you are ready to be able to apply. And really, you need to be thinking about it from the time you start your urological training to ensure that you are on track, because waiting 6 months before your CCT is the wrong time. It does mean the TPDs and the liaison members at the ARCPs are going to have to be very proactive in identifying your deficiencies within your training and program. The other thing that's out there at the moment, anybody that's going out on maternity leave, out of program experience, career break, or research will have to do a return to work program. And this must be done and agreed before you actually go out on that program. There's been debate, particularly in the most recent national selection. We had to change our portfolio station because we were an outlier. We've realized from the portfolio station at national selection that the process that has been adopted has not been ideal, and that will have to change because it favours a lot of research and having done an MS or MD, and that is not ideal. Toby Page has already alluded to BJUI knowledge. And one of the things that's been discussed in BJUI knowledge is mapping that BJUI knowledge for trainees against the curriculum, and this will be the rewrite of the curriculum, such that you would potentially be able to use BJUI knowledge as not only your source of knowledge in terms of information, but potentially with your in-service exam as well. And that's something that we're looking at in the background. We've all surgical disciplines have been asked to say what are their critical conditions. In other words, what have you got to be providing evidence for CCT? These are the critical conditions that you will now have to provide evidence for with workplace-based assessments, either as mini-KEXs, WBAs, or what have I missed out? WBAs, PBAs. See, yeah, absolutely, right? Mental block. But these are the ones, and you will have to provide evidence of these at your ARCP. And what they have been done is built into the waypoints, which is I'm talking about next. One of the things that we're going to, you're having problems with at the moment is you're coming up towards CCT, and a lot of you are not getting your core urology or where you should be with your core urology. By introducing waypoints, and we've decided just to do it for ST4 and ST6 rather than every year, is this will give you help and clarity about where you should be in terms of your training, but more importantly what it will do is allow the TPDs to start directing your training. Because where we are with training at the moment is you have posts in teaching hospitals and DGH, you are put into posts to ensure that they are filled. Whereas the TPDs are now going to have to think, well, I have a core trainee, and they are going to have to develop and deliver these competencies by this time. Because when the new curriculum is rewritten, that we're all going to have to do, we are going to be embedding waypoints into the curriculum. So they will have to be delivered, and the TPD will have to ensure that you get there. So this is, at the moment, giving you guidance about where you should be, but will be a huge driver for TPDs to deliver. The research guidelines at CCT are changing. Instead of having to have 2 first-order publications in peer-reviewed journals, you will have the option of what is set there or set there below. But already the GCP and research methodology courses are there, but we are going to be developing within BAUS a research methodology course that you can actually do here at the main meeting. There is debate regarding the pediatric urology, but for those of you that don't know, the country, i.e. HEE, are not happy with the way emergency surgery for common conditions in urology and general surgery are being delivered. So they have developed guidelines nationally for emergency surgery in children, which general surgery and urology are going to have to deliver. General surgery have rewritten their part of the curriculum related to emergency childhood surgery, such they now have to be able to deliver torsions, etc. So consultants in urology will have to be teaching surgical trainees till they're competent to be able to do the emergency surgery. The problem with surgery in pediatrics, it's not just surgery, it's dealing with the family, it's dealing with the all the safeguarding and issues that are around it. So unfortunately, we're going to have to develop a program that fits the delivery of surgery. So what is going to be expected is the equivalent of 3 months or 40 days. That can be determined by the TPD, how that 40 days is done, either as half days, as full days, or a mixture of the two, or the allocation of 3 months if the program is able to deliver it. But in terms of the workplace-based assessments, we're expecting a spread across it, and you will have to do safeguarding level 1. Most of you will have that in mandatory training within your trust anyway, so it's nothing extra to add. In terms of indicative numbers, these are the indicative numbers that exist. As you know, within the last year, ileal conduits have come in at level 2. We're realizing there's a shortage of exposure to emergency surgery, and the ileal conduit, in terms of the surgical technique, is a transferable skill that will transfer across to emergency surgery. Indicative numbers, they're going to change in terms of, it says trust there at the moment. We're going to include transperineal biopsies. The 300 for cystoscopies is going to include rigid and flexible. A lot of you are saying, why have we got to do 300? You don't need to do 300, yeah? So it's going to include rigid, as well as going to go down to 10 rather than 20. There's been a lot of debate regarding cystectomy. As you know, it went down from 2 to 1, but what trainees are doing at the moment is they are just going and watching, and they're not doing any workplace-based assessments that are of any value. So cystectomy is going to go back to 2, like the ileal conduit, to give you the exposure in terms of the surgical skills that will make you more readily available to develop and be able to use those emergency skills. So that's where we are at the moment, and now are we open for questions now? Thanks very much.
So I think it's really important for us to hear the questions from the audience, and there is some strong opinion on the anonymous question. So I'd like to invite all the panelists back up for maybe a hard time.
We've got enough, haven't we?
So I can see a hand on the floor. Lady at the front here in the red top. Is there a roving microphone, please?
So we can't hear.
Yeah, there's a microphone coming to you. It's just important everyone hears.
Hi. I might be wrong about this, but it was my understanding that training had been like this before, where you had coupled SHO training and registrar training, and then it changed back again. And it sort of feels a little bit like, maybe are we not just going round and round in circles with this issue? And what were the reasons that they decided to uncouple it again? And are we going to be discussing this issue again in another 7 years, where we uncouple it all again?
The first thing to mention is the biggest driver is HEE, i.e. Health Education England, rather than the SACs. That's the first thing to mention, because HEE want to make sure that the improving medical training and improving surgical training and medical training will happen. So that's the first thing. The problem that we have with urology, and you need to think about, is the reduction in number of trainees that are going into surgery. The most popular specialities that are sitting out there are the ones that offer run-through training. Neurosurgery has a mixed economy. The majority go in at ST1, but some of them can go in at ST3. Cardiothoracics, you can offer a mixed economy, but they go through at ST1. They are the most popular specialities, and neuro particularly, because it offers surgical training at ST1. Trainees have already said they want to stay in a region really early on. And the demographics of people coming into surgery is such that we are seeing a lot more women in surgery. Nearly 40% of all trainees that went into surgery were women last year. It is very, very high. They want to stay, and they want to be able to make a decision early on. If we don't have a mixed economy, and that's where I think we should be, is a mixed economy of ST1 and the option of ST3, because there are some core trainees that don't make a decision till their core time. They've not made the decision at ST1, so they will have the option going forward. And the surgical specialities that are thinking early are thinking of a mixed economy. I hope that answers the question.
So one related question from the app, then we'll go back to the floor. So the question was, how do we expect to increase recruitment to urology when trying to recruit to run-through programs after foundation, when only 8% of foundation trainees experience any urology at all?
It's probably for Toby, that one, isn't it?
Yeah, I mean, it's a pretty unanswerable question, and I think that's where BAUS is working with the medical school curriculums to increase exposure. But equally, it goes back to what I said about all of us at every grade have a responsibility to engage with medical students. Because with the best will in the world, the medical schools and the foundation programme isn't going to favour urology as much as we would like. So I think there's a responsibility for all of us to promote our speciality at every opportunity.
Okay, Lucy?
I was just going to say, sort of on that vein, you said the driver for recoupling training is coming from HEE. Have they seen that 50% of FY2s are leaving medicine? Have they seen the increasing unrest amongst junior doctors? Do they really think that forcing people to choose the rest of their life at that point when they've only had 2 years exposure to medicine outside med school, which we all know is a very different ball game, is the correct way to increase people's satisfaction and, you know, long-term lifespan in a specialty? I think it will only drive people away.
The driver for it, they know about that, but the driver for it is the dissatisfaction, and we're talking about IST, i.e. surgical training here, is the dissatisfaction at core level. So it's to try and improve the training at core. That's what the big driver is. And to give them much more time with training at core level.
So another question from the... Jimmy, did you want to... Okay. So another question from the app was related to that. What effect do you think that the constant changes in urology CCT requirements have on trainee satisfaction?
So basically my message, the crux of my message is that, you know, the training is a dynamic process. What we started about 30 years ago, we started with open operation, then came the laparoscopy, and now we're going to the phase of robotics. So if you are going to be practicing next 30, 35, 40 years, be flexible that you will be prepared to every 10 years something might change, and therefore you should be prepared to change. Satisfaction is something, it is very difficult to define because there are so many other elements to your job and working life pattern brings. My feeling is that it all depends upon where you're working. If you're working in a very good department with good colleagues, no matter what you are doing, you'll be a much more happier person. But if you are unfortunate enough to be working in a department where you are not a coherent team, you are not supportive of each other, then of course, no matter what you do, you may be a brilliant surgeon, but you may not be very happy. So it's a fine balance to strike between your relationship with the rest of the team members and also being prepared to change if that is what is needed with the time.
Okay, does someone have a mic? Lady at the front, please.
Hi, sorry, Holly from Lee Park. Just a curiosity, really. The Shape of Training report, which I don't necessarily agree with but have read, wants us all to be generalists earlier and doesn't seem to approve of specialization particularly. Where does that fit with improved surgical training and getting people into a surgical specialty earlier? It's just all very confusing generally.
That bit, if in terms of the overall numbers, in terms of the shape for training,
Yeah.
by far and away the biggest cohort is medicine. Yeah? In terms of overall numbers, surgery is a small part of that. But the driver, again, is HEE wanted to ensure that the appropriate person was available to treat the appropriate patient, particularly in an emergency setting and particularly for emergency medicine. You are ending up with a problem, particularly in emergency medicine, that the majority of consultant physicians were so subspecialized that they could not deliver. So it has been a bigger driver for medicine than it has for surgery, but that was the driver for it.
Thank you.
Okay, last few questions now. A popular one on the app. Is there a regional difference in the country in training satisfaction and outcomes? For example, do trainees in the north fare better than trainees in the south when it comes to indicative numbers and research opportunities?
The first answer is that there doesn't seem to be a huge difference in terms of trainee satisfaction. What there does appear to be, though, is a regional variability in access to some areas of the curriculum. There is a disparity in availability of pediatric urology, although the SAC and BAUS have looked at the availability of paediatric numbers across the country. And what we do know is the opportunities are there. The problem is that the TPDs are not necessarily all the time identifying those opportunities and giving the trainees time or allocation to them. To a lesser extent, that exists with female urology and andrology, but it's not such a problem. There's been a recent, and I know Pippa Sangster recently did a survey for you for the andrology, and again, essentially, the result of that was, and I think some of you went to the talk, but not all of you, did actually show that in the majority of situations, trainees were quite happy with the exposure that they had to andrology, and that there weren't massive regional variations. So there's not a huge amount of variation in terms of satisfaction across the training programs.
May I add one point? Just to add to your indicative numbers, I personally think you should more be focused on competence rather than just the numbers. You might have done 100 of something, but if you don't do it well, as a consultant, you will face problems. So therefore, be focused on competence, achieving competence, and be competent at a particular procedure rather than just saying, okay, I have completed 120 of TURPs, and therefore I am okay to do any TURP. It is not the case. I think you need to focus more on competence levels so that you are comfortable as a consultant and be able to practice independently.
And I think that's a very, very good point. And you may ask, why do indicative numbers actually exist? Well, all the surgical specialties have indicative numbers. They were introduced as a surrogate marker for competency, but they're there to support the competency. It's important as far as CCT is concerned, they're guidelines. A lot of you are chasing the absolute numbers. Part of that is driven by the TPDs, but we have told the TPDs that you need to be around there. You don't have to have the exact number. That is a CCT guideline. So if you are 10% off, and that is the leeway that the majority of the SACs are allowing, then providing the rest of your portfolio is up to scratch for CCT, being 10% off on an indicative number will not fail you. What will fail you is if you're 10% off for all of them and the rest of your portfolio is not very good. But see, the indicative numbers are surrogate. The most important thing, as Professor Khan has said, is being able to demonstrate the competency. And as far as the competency and a guideline you need to be able to take away is in your last 2 years, you need to be able to demonstrate at least 3 of that competency that is needed for CCT. But it's competency. It's a competency-based curriculum.
We've got a few questions, and I know we have one other item, but I'm quite keen to keep going on with these questions. I think we both agree that it's in our interest to find out more. So I'm going to take one from the floor now. Dora?
I just wanted to come back to the foundation trainee satisfaction. I think most of us can probably remember our foundation years. They're not particularly enjoyable, but you aspire to be someone ahead of you, and you look at the urology registrars back then, they seem to have quite a nice life, and now the foundation year doctors that I spend time with, they see me as Reg of the Week, leash to a bleep, putting catheters in on medical wards. I can't see that they're particularly inspired by what they see every day, and I just don't know how we can change their exposure to the specialty, given what you see day to day on the ward.
Yeah, I think one of the things that hopefully will change in the next quite near future will be a much clearer protection of training for ST all the way through. So decoupling of what you describe as service delivery and training. And at the moment, it's got very blurred between it. And I think we need to identify those training opportunities and protect them more than we have. Yes, there will always be a service commitment. That's part of being a doctor. And absolutely, I appreciate what you're saying. It doesn't look good to the foundation doctors. But if we can, on the other hand, give good quality protected training, then the foundation doctors will see that and see the benefit of a well-structured training program.
And if I can just support that, we've actually got Ian Erdley here, who's vice president of the college and the driver on IST, but he wanted to keep quiet in the background. But one of the things that is being promised as part of the IST is actually more dedicated to training time for the trainees, but also for the trainers. Yeah? So the trainers will have more time to train. At the moment, there's a huge push towards service. There are good trainers and there are bad trainers. In the IST project, good trainers will be identified and will be supported through their training. It does mean there will be a shift in terms of delivery of training for those that are good trainers and train well, to those that will also do more service and less training.
You said that foundation training would largely stay the same, but I think that some of the dissatisfaction with the SHOs is that the F1s are on the ward for a week and then it's a different F1. So there's no continuity in the foundation training. So your foundation trainees don't want to be SHOs because they just don't actually understand the speciality. The SHOs end up doing the foundation training work, the registrars end up doing the SHOs, and surely we need to address it from straight out of university, not just from a core training level. Are we going to look back at foundation and all of these community posts that have come in and taken away a lot of the F1s, meaning that the dissatisfaction is only growing?
Yeah, so I think the big change will be physician's assistants. So this will be good for all of you. You may not think it's good, but it will be. And that will make the foundation job, a lot of the service delivery of foundation job will move on to physician's assistants, which will allow you more time for training. What you say about perhaps the softer areas of the foundation years still have to be covered. So that is the landscape we live in, that they will have primary care attachments, old age psychiatry attachments, whatever they are. That won't change. But when you are in a surgical foundation job, if you are supported by a physician's assistant, you will be learning, you'll be getting to theatre, you won't be doing a lot of the drudgery and service commitment that you're doing at the moment.
I think the physician assistant's roles need to be clearly defined, because you do end up in a situation where the physician assistant is the person that stays and the person that rotates through is the trainee. So there's always a slight favoritism, unknowingly almost, to the physician assistants. And I think sometimes it's not clear exactly what the role is within.
So Ian Pearce has written a curriculum, urology curriculum for urology physician associates, and it will be published on the BAUS website probably next couple of weeks, so you can look at that curriculum.
I think it's really important.
So one point, Toby, so I'm part of the Royal College of Surgeons patient liaison group, and one of the issues that we've been discussing is the wider surgical team, which we've been endorsing quite widely. In GP training recently, they've announced cuts to training of GPs for the funding to go towards physician assistants. Is there a danger that that might happen in surgery?
No, is the answer to that. I mean, we saw Kieran O'Flynn's president's address that there is there's a potential for a real shortage of surgeons. So I think it's unlikely that there will be a cut. Equally, I think it's probably, maybe Roland will know, I don't think there's going to be a big increase in numbers either.
Sophia?
Slightly different topic. I think the courses, the ST3 boot camp, the ST5 emergency course, and the ST7 leadership look fantastic. However, I'm mindful training is getting very expensive. Are these likely to be funded?
Right. The big push at the moment with the rewrite of the curriculum, with the improving surgical training, is to include simulation within the curriculum. If you're including simulation within the curriculum, it will have to be funded in one way or another. And David Wilkinson, who's the lead dean for general surgery and urology, is going forward to HEE asking for extra funding. Now, at the moment, we have no guarantee of getting it, but there is an assumption that we will get it. If you think about it, the patient is center here. The patient wants us to be trained. They want us to be ideally not training on a patient first. They would rather we were training in a simulated environment. There is a lot of evidence out there that simulation does benefit. What we don't know is how much it benefits, but it does benefit. And if we can show that simulation does benefit, then it will get paid for. But The converse to that is there is only a limited amount of pot sitting there within the NHS, and there will have to be redistribution of that money.
Okay, one question from the app. Access to peds, andrology, female urology is very variable across hospitals and deaneries. With whom does the responsibility lie to ensure that all trainees within a region have adequate exposure for CCT? TBDs or trainees? I think a combination.
Ultimately, it comes down to the TPDs, but there is absolutely no doubt that trainees have got to start driving some of their training. I mean, I don't want to be pessimistic, but when we came up through the older style system, we did drive our training. There is an assumption, not necessarily with surgical trainees, but some trainees, that they should be spoon-fed what is out there. We have to earn our training and delivery of our training. Most of you know where those opportunities are. You can actually help drive that with your educational supervisor and your TPD. The TPDs are there to support you, but you have to be proactive in terms of your training. Don't just sit there and expect it to be delivered to you. You have to be proactive, because TPDs are not perfect. They may not realize that you are short at a particular time, although these waypoints will actually help. You need to be proactive with your TPDs, you need to engage with your TPDs, and you need to meet them on a regular basis. And as part of the improved surgical training, that's what the educational supervisors will be doing. They will be given more time to deliver your training.
Are they going to be paid for training?
Who?
The trainers.
The trainers are not going to be paid for the training because there's only a certain amount of money in the pot. But what will be is redistribution of their working environment. So the good trainers will be training. The bad trainers won't necessarily be training all the time. They will be doing more service delivery, but they'll still be paid within their setup. And the GMC are actually very keen on driving that forward.
Okay, right at the back there, he's been waiting for some time.
My question is a broad one. Have health education become complacent, or are young people more selfish about their original quality of life?
Sorry, we can't hear very well.
Can we get the mic to him, please?
Have health education, England or wherever, become complacent, or are young people now more selfish about their need for quality of life?
I think we've seen a huge change in the population, and I think trainees nowadays, not just surgical trainees, but trainees across the whole board, want a good quality of life. And HEE and the training organisations need to realise that is what they want.
Yep, at the front here, please. Yep, lady here.
When you were able to drive the training, were half of your registrar searches gaps unfilled? And did you have full complement of SHOs, which you no longer
No, as the person most recently out of training, I had at times the similar problems that you've had, and I think those problems have always been there. And actually, it goes back to the other question about quality of life, and the problems have been there, and there is a responsibility both on trainers and the trainee to get around these problems. It goes back to that slide I showed of 50% dropout. Unless we can stop that 50% dropout at FY2, these gaps in core surgical and foundation rotas will exist because there will be gaps there. So it probably actually goes back further to foundation years to try and keep people, rather than saying, I'll drop out, I'll go off, I'll do something else, keep them in the system so we don't have those gaps. But they have always been there. You're not alone on that. No, but the rotas in those times, the rotas were different, and we had different working practices, but there were always gaps, people being away, absence, paternity leave, maternity leave, whatever. So there have always been gaps on rotas.
Kenneth? Speak up, please. I think that they've gone home, maybe.
Gone.
So you might have to shout.
consultants. I'm not joking. I think that for many years, the health services relied on doctors in training to deliver far too much service delivery. And the NHS has changed. Patients have changed. They expect more consultant input. They expect more consultant input at the start of their patient journey. And I think in the longer run, that will be delivered by consultants.
The only problem with that is consultants are expensive, but he's absolutely right.
And in fact, that's actually taking place now. John Alling from Newcastle did tell me earlier today that once the trainees done their flexis for CCT, the consultants now need to cover some of their lists. So it's happening. Okay, lady in the back in the green.
The big change that Toby and I have already alluded to is the extended workforce. So it is the use of all those other medical personnel that we're not using at the moment. But that is a risk because it hasn't been identified where they're all coming from yet. The biggest change that you noted on one of those slides and related to that improving surgical training was the surgical cells. The biggest problem that you have at the moment is small numbers on a rota which make training almost undeliverable. Within the improving surgical training, it's the bigger cell in terms of delivering. And by having the bigger cell in terms of delivering the service in a rota, more people within that system will then be available for the training. Right, at ST1, I didn't put all the slides up that I could have done, but at the equivalent CT1, CT2 level as it exists at the moment, they will be delivering and learning a lot of core surgical capabilities. So it will be general surgery. They will potentially have access to vascular surgery. They will potentially have access to gynae because it's a transferable skill and it is something that we have to do. So they will be learning core generic surgical capabilities. It won't necessarily be purely urology at, well, it definitely won't be at ST1. Because you have to develop and learn the core generic skills.
I think this has been a very fruitful meeting, but unfortunately I will have to wrap up now. Please do come up and ask any specific questions if they weren't answered. I know there are a few on the app. And I'd like to thank Professor Khan, Mr. Morley, Mr. Page for your time. I think it's been a good get-together, and we'll see you at the dinner, those that are coming.